severe. Okay, let me see what I can do for you. Because I need to put you on treatment right away. So those are they're going standard now. Medical insurances start kicking in for these. Because they're so accurate, they say, why not? Let's use them. So a lot more people can get diagnosed now. Sometimes before we go to the diagnosis, we just have questionnaires. Let me ask you a couple of questions. And this is one about sleepiness. So here there are like a couple of situations. Sitting, watching TV, sitting inactive. And you tell me from 1 to 3, what's your chance of dozing? When you sit and read, it's 0 or 3. If it's 1, there's a slight chance. Okay, let's go. Watching TV. If I watch TV, what's my chance for 20 minutes? 0 or 3? 2. And you start adding these up. And if you are above 10, we can say, yes, you might have sleep apnea. And there are a lot of questionnaires like that, which takes into account like snoring now. Okay, is somebody experiencing any snoring? Or do you feel tired? And also blood pressure. When we put it together, we have a better questionnaire, this one. Or another one that takes into account now gender, and if you observe the person next to you stopping reading at night. Because that's one of the key features. You can come to me, you can be 400 pounds, you can be the most tired and fatigued person in the world during the day, you will not have sleep apnea. Or you say, oh, I snore like crazy. You might still not have sleep apnea. But if I ask your partner, and the partner is saying, also, I witnessed him stop breathing for a couple of, 10, 15, 20 seconds, and I have to kind of, hey, wake up. Oh, that's when my light bulb, my bulb's gonna light up. That's the key feature, if I see that. So a lot of things could happen, snoring. Not everybody snores and has sleep apnea, but that breathing stopping during the night. So we talked about the diagnostic features. Snoring is going to be the main one. Okay, for sure, people that have sleep apnea snore. Okay, but doesn't mean like if they snore they should have sleep apnea. So only 6% of patients with OSA did not snore. So pretty much everybody snores. With this apnea, big thing, nocturnal choking and gasping. That process, that phenomenon during the sleep, during the night, witnessed by the partner. I don't know about all this until my wife is telling me. You do this. Okay, that's a question mark. Insomnia. Some people might have insomnia, and that can start, the sleep, obstructive sleep apnea can start with insomnia. I mean, heavy insomnia, that can lead to the actual disease. Those were at night. During the day, you have all this excessive daytime sleepiness. And then I can use questionnaires to find out if you actually have excessive sleepiness. Then you have all the other ones that we talked about. Do you have fatigue? Because that's what actually, if you go to the sleep clinician, they're asking you about all this. Am I correct? Yes. Are you fatigued? Do you experience mood changes? Do you feel like you're losing memory? They will ask you about all this. Okay, this is part of their interpretation of the disease. It's not like everybody that steps into a sleep clinic, they put them through a sleep test. They don't have time. It costs a lot of money. They don't have the space for that. Now, this is one more thing that I want to show you. There's an overlap. Remember I told you a lot of patients with COPD might have sleep apnea? When you put them together, very big issue. We call that overlap syndrome. Patients with, doesn't work anymore. Patients with OSA prevalence of COPD is 14%. Patients in gold stage 4, the prevalence of OSA is 43%. So half of these patients, severe patients, COPD patients, have sleep apnea. That's what I want to show you. One disease with the other disease together don't make 2. They make 3. So if you have COPD and OSA, everything else is going to be exacerbated, but not by double, but more than that. That's the paradox that we have to face some of the other diseases. When you add one on top of another, doesn't mean, oh, the change is going to double. No, it's going to be more than that. And you see the patient being predisposed to respiratory failure, pulmonary hypertension, more than they will experience that by having just one or the other. And this is going to show you, you will understand that a little bit better. So, onset of atrial fibrillation. Here's give you an example of a cardiovascular problem, an arrhythmia. Patients with just patients with OSA. You see the number, just 7% of patients with OSA experience atrial fibrillation. Patients with COPD, 11%. When you put them together, you think, okay, 18%. It's actually 21%. You see the increased risk just by having both diseases, COPD and OSA, together. And then other conditions who might have atrial fibrillation, just 5%. In conclusion, like I said, I like this disease. You know why? Because it's easily treatable. I have a treatment that works. But what do I need? I need to diagnose the people. I need to make sure people, as soon as they see those features, clinical features, in themselves or in others, at least pose the question, is sleep apnea a possibility? And then somebody else will answer. A primary physician or a family physician, a sleep physician. Most likely the family physician is going to refer you to the pulmonologist, the sleep physician. But at least have in mind, somewhere here in one of those little drawers of your brain, when you see things that we've been talking about. I'm not responding to blood pressure medications. I have a big neck. I witness these, apneas or choking at night. All of these. What's next? What should come into my mind? Sleep apnea. So who's more likely out of these two people have sleep apnea? Okay.
On the left.
Then you add, so big guys, you have the snoring, not uncommon. Like I said.
He's trying to travel bus.
And then you have the sleepiness during the day, and you have a pretty good understanding of what's coming up. And this is one of the treatment like this, sleep apnea, one of the masses. So, thank you for your time. If you have any questions, I'll be really happy to answer any questions. Thank you.
We have questions back here?
Yes.
Just real quick, historically, when did they start to recognize sleep apnea as in 1950, 60, 80?
There were periods in 1800s when they're talking about, and I forgot the folklore, especially in the U.S., they're talking about a little boy, chunky, what's that, Big Joe, or what's his name? What?
Bob.
Big Bob. And a description by one of those novelists was Big Bob, fat and chunky and sleepiness all day long, or sleepy all day long, something like that. And then in the medical journal said probably this is it's a condition, or they didn't have a name for it. The name obstructive sleep apnea came, I think, in 1980s. But it was recognized. It was recognized, but not for something, because remember it was about, oh, I'm sleepy during the day. Who cares? But then they find out the connection with the heart disease. They find out, oops, it's not just about losing some of the memory and being sleepy during the day, because you can look everywhere people are sleeping. I have pictures with Dick Cheney always falling asleep in those meetings. That's fine. But as soon as I tell you, oh, that triggers a heart attack, that triggers a stroke. Then people, oh, let me get diagnosed. Yes.
We have a physician here that actually runs a program for sleep apnea. He didn't begin to do what you've done. You've done terrific, but he did talk about it. When he first came to Richmond with this psychiatrist degree, to work for the VA, they asked him what he wanted to do. He said, I want to do sleep apnea. And back then, they considered sleep apnea part of the brain. There was something wrong with your head. And that was in the 80s.
Yes. That's why they didn't have that obstructive sleep apnea until like 1989 or something. The term was coined.
What's a bypass machine?
The BiPAP machine, it stemmed from that difficulty of you breathing out, exhaling, because you're constantly receiving a flow of air.
So it reduces the pressure.
Reduces the pressure and is calculating, okay, how many times do you breathe in a minute? 13, 15 times? Okay, so